Okay, so we'll get going. Welcome everyone today. Thank you very much for signing up for this webinar. My name is Lizzie Kirkham and I am a researcher at the University of Edinburgh, and I also work on the CoMorMent research project. Many of you will know that there are some stark statistics when it comes to mental health and physical health. People with various mental health conditions experience a drop in life expectancy of between 10 and 20 years on average. And this is largely due to increased rates of cardiovascular disease in this population. So the CoMorMent research project has been designed to learn more about this problem and what we can do about it. So today we're going to hear from 3 people working on the CoMorMent research project. They are from across various countries in Europe, and they are going to talk about some of their specific findings. And then after that, I will introduce the new co-produced guidance that we have developed, which is basically designed to help health professionals who have heard about CoMorMent's findings understand how they can use that in their clinical practice. At the end, we will have a question and answer session with all the panelists, and please feel free to write questions in the question and A section at the bottom as we go along. So thanks again for coming, and now I'll introduce our first speaker, Linn Rødevand.
Thank you. Share screen. There you go. You can see my screen okay, the presentation? Okay, good. So, as Lizzie was saying in her introduction, there is a connection between mental and cardiovascular health. But what is the latest research on this, and especially regarding the role of genetics, loneliness, and lifestyle? And how can health professionals use it in their clinical practice? This is the topic of this talk that I would have for you today. And severe mental disorders, including schizophrenia, bipolar disorder, and major depression, have up to 20 years shorter life expectancy than the general population. And the major cause of this premature death is cardiovascular disease. And importantly, comorbid cardiovascular disease is associated with poorer quality of life and more severe illness course, which stresses the need for better prevention of cardiovascular disease in severe mental disorders. An important question is, why do people with severe mental disorders have an increased risk of cardiovascular disease? While the causes are complex and not fully understood, likely contributors are those listed here, including lifestyle such as poor diet, physical inactivity, and smoking. In addition, loneliness is associated with increased risk of cardiovascular disease as well as premature death. And it's important to be aware that loneliness is a major challenge in many people with severe mental disorders. Another factor that might play a role is genetic susceptibility to cardiovascular disease, which I will get back to. All of these 3 first factors here. But other contributors might be side effects of psychotropic medication, poor somatic healthcare, stressful events, as well as socioeconomic challenges. And when it comes to this genetic susceptibility or genetic overlap, this might involve genes that have an direct effect on cardiometabolic disturbances, but it can also involve genes that have an indirect effect through brain function, which regulates behavior and psychological traits, such as lifestyle and loneliness. And with this in mind, we investigated if there is genetic overlap between severe mental disorders, cardiometabolic factors, as well as lifestyle and loneliness. So now I will give you a brief summary of these key findings before I move on to how this can inform clinical practice. So first of all, we have found extensive genetic overlap between loneliness and severe mental disorders and cardiovascular disease risk factors. And there seems to be that a genetic vulnerability to loneliness may increase the risk of severe mental disorders and cardiovascular disease. In these Venn diagrams, you see an illustration of the degree of genetic overlap between loneliness and depression, schizophrenia, bipolar disorder, as well as body mass index. Secondly, we also found shared genetic variance between bipolar disorder, schizophrenia, and different risk factors for cardiovascular disease, such as cholesterol, blood pressure, and type 2 diabetes. But in contrast to the finding for loneliness, this shared variance seems to have mixed effects, indicating that half of them are associated with increased risk of both bipolar disorder and schizophrenia, while the other half is associated with decreased risk. And this variation might suggest variation in risk of cardiovascular disease across subgroups of patients. Thirdly, schizophrenia is associated with reduced genetic risk of obesity, which might seem surprising, while increased genetic propensity to smoking. And finally, both schizophrenia and bipolar disorder show some surprising association with lifestyle factors, including increased genetic propensity to choosing healthy foods and physical activity and less sedentary screen time. Here you see a few more illustrations of some of these key findings, with schizophrenia sharing considerable genetic influence with both BMI, smoking, and healthy foods. So how can research inform clinical practice? So the loneliness finding calls for greater recognition and integration of loneliness in the treatment of people with severe mental disorders. And this implies that it's important to routinely assess the quality of their social relationships and loneliness. And detecting loneliness early is key to prevent the feeling from becoming an enduring condition with negative health effects. And as some patients might be reluctant to admit to the feeling of loneliness due to shame or stigma, a combination of direct and indirect questions related to loneliness is often recommended to capture the feeling of being alone. And currently, there seem to be limited effective loneliness interventions for people with severe mental disorders. But recent findings do suggest that interventions that help them reframe their social expectations and interpretations could be helpful. And that is because loneliness is associated with negative expectations and interpretations of social encounters. However, these approaches are, of course, only likely to be effective if they are provided together with other efforts to improve the opportunity for social participation and employment. So therefore, it is important to support the patient in finding social activities where they can meet other people and find healthy sources of social contact. The finding of shared genetic variance with mixed effects in schizophrenia, bipolar disorder, and cardiovascular disease suggests variation in liability to heart disease across subgroups of patients. And this has important clinical implications, highlighting the need for personalized pharmacological treatment based on the individual's genetic risk. In addition, it emphasizes the importance of regular monitoring of adverse side effects, including metabolic disturbances. The finding of increased genetic propensity to smoking is important for clinicians to be aware of, because it can increase their understanding of why a large proportion of the patients do smoke and why it's difficult to stop smoking. And by expressing this knowledge to the patient, the clinician might help them gain a greater understanding of his or her own vulnerabilities and struggles, and also reduce self-blame. In addition, this findings highlights the need for more targeted smoking interventions that help identify the factors that contribute to smoking and finding alternative strategies that might help quit smoking, such as medications and other ways of coping with stress. And the finding of the finding of reduced genetic risk of obesity in schizophrenia suggests that the weight gain that we do see in many people with schizophrenia is probably secondary to antipsychotic side effects and unhealthy lifestyle. And this again highlights the need for a regular monitoring of weight gain, especially among those using antipsychotic medication. And the findings also underscore the need for more targeted lifestyle interventions to facilitate a more active lifestyle with better diet. And to further increase the motivation for physical activity, the clinician should inform the patient about the beneficial impact of activity on mental health. So I'm getting close to the end here. The finding of increased genetic propensity to healthy food and physical activity in schizophrenia and bipolar disorder is quite surprising, and suggests that there are these lifestyle factors, unhealthy lifestyle seen in these patients are not driven by genetic liability, but that there are other factors that play a role. And this highlights the importance of targeting those factors that do contribute to unhealthy lifestyle, and to provide more personalized pharmacological treatment to limit side effects that might contribute to poor diet and inactivity. So in conclusion, the findings can be translated into clinical practice by providing a more integrated approach to individuals with mental disorders, by focusing on tailored medication, weight monitoring, as well as loneliness and lifestyle interventions. Thanks to all collaborators at CoMorMent and CoMorMent. That was it for me.
Thank you very much, Linn. So thank you. We've got one question in the chat, which we'll come to later on. Please continue to put question and answers in the Q&A section. And now we are going to hear from Patrick Anderson.
Should remember to unmute also. Do you see it okay now? And you see my pointer also?
Yes.
Yes.
Okay, great. Okay, so as the title says, I will talk about hidden weight gain, adverse muscle composition, and cardiometabolic risks in antidepressant users within the UK Biobank. So first, you might already know, but UK Biobank is this huge health database with more than 500,000 individuals first collected in a baseline visit, and then part of that population are re-invited for a second visit several years later, where they resample data but also collect imaging data, for instance MRI data, and I've been using data from the first 40,000 individuals that they collected MR data from. And if you look at antidepressant usage within UK Biobank, there are two types of antidepressants that are most prevalent. Those are SSRIs and TCAs. The other ones I didn't find enough people to do much with. So the analysis you will see is from SSRI and TCA users. And then excluded individuals that were on antipsychotics due to overlapping side effects. If they were switching or using multiple types of antidepressants, so switching between baseline and imaging. And then due to analysis that you will see later on, I excluded individuals that had cardiovascular disease or type 2 diabetes pre-imaging visit. So the cohort I ended up with is, the overview of that is in the table at the bottom, divided into female and males, and into SSRI users and TCA users. And the largest group is the female SSRI user group. That's 884 individuals, and then it ranges all the way down to 160 individuals. The smallest group, those are the male TCA users. And they are, on average, all groups are overweight with BMI 26, 27, 28 or so. And as usual in UK Biobank, they are slightly older, so average age is between 61 and 66. So that's the population we have to work with. The first thing we did was to look at weight gain and ask the questions if the antidepressant users gained weight between baseline and imaging visit. And since the time between those visits varied a lot, we used the BMI per year, so change in BMI per year between the two visits. And here on the left, you can see bar plot of the antidepressant users, the SSRI users, and the TCA users, females in red and blue, male in blue. And to the right of that, we see the change in BMI per year for matching controls. So for each antidepressant user, we found 3 controls with the same sex, age, and BMI, and created control groups like that. But what sticks out here is this one big bar, right? That's the female SSRI users. They tended to gain more weight than the other one. It was significantly more than the male SSRI users. So comparing these two, and then also significantly more than the control group for the female SSRI users. So this is the changing weight, but we are really after more detailed questions. So the question is if people are on antidepressants display a different body composition compared to individuals with the same sex, age, and body size. So for that, we used MRI data. You can see an example of an individual and a fat channel and muscle channel coronal slice for one individual. And the body composition measures that I've been using here are these 5. You can see them colored in the slices here. We have the subcutaneous fat or abdominal subcutaneous fat in light blue here. We have the more nasty visceral fat around the organs. We have muscle volume, so in this case the thigh muscle volume, and we have the fat infiltration in these muscles, so indicator of the quality of the muscles. And then lastly we have the liver fat. However, we do not use these measures directly as they are. We compute what we refer to as personalized set scores. So the short description of what that is it's a description of, for each individual, how many standard deviations that individual differs from what you would expect based on a population with the same sex, BMI, and age. So if you, for instance, consider the thigh muscle volume or the muscle volume set score, if it is 0, it means that this individual have exactly the same muscle volume as you would expect from the BMI, age, and sex. Then I have another example. If someone has a visceral fat set score of -1, it means that you have 1 standard deviation less visceral fat than what other individuals, so what you would expect from the BMI, age, and sex of that individual. So we computed for each of the antidepressant users these set scores for these 5 body composition measures. And here we see bar plots of the average set score for SSRI users and TCA users. And again, females in red and male in blue. And it's a lot of information in this plot, but if we focus on some things, we can see that, again, comparing to individuals with the same sex, BMI, and age, all the groups really tended to have a tendency towards adverse muscle composition, so smaller muscle volumes and more muscle fat. So the wrong direction of both these measures, and this has been it's been shown in other studies that this is related to all sort of clinical problems, so that's not good. Another thing to notice is that when comparing female and male SSRI users, remember that female SSRI users was the group that gained most in weight between baseline and imaging. Here we see that on this set score profile, let's say, male SSRI users is more showing a more negative trend, like they have more surprisingly high subcutaneous fat, visceral fat, smaller muscle volume, and well, muscle fat is about the same as for the females, but show something different than just looking at the weight gain. Then we also asked if people on antidepressants have a higher risk of developing cardiovascular disease. So we see here on the left a Kaplan-Meier plot for SSRI users. So this shows, remember, they didn't have any cardiovascular disease before the imaging visit. And then we show a risk plot of days since the imaging visit, how high what's the cumulative rate of CVD incidences. And blue is male, red is female, and the dotted line shows the curves for the control groups. So what we see here is that for male SSRI users, you have a higher risk of developing CVD compared to controls that are matched on BMI, age, and sex. This was also tested in a regression model where we corrected for different lifestyle variables and depression level and so on, and still significant. And then we did the same thing for type 2 diabetes, so asking the question if people on antidepressants have a higher risk of developing type 2 diabetes. In this case, it's the TCA users that we see something in. So this is the same type of plot for TCA users. And here we can see for both males and females, there seems to be a higher risk of developing type 2 diabetes over time compared to the matched controls. Again, confirmed with a regression analysis with the same types of correcting factors. And we also did a test to, we separated the individuals that only used the antidepressant at the imaging visit and the individuals that also used the antidepressant at the baseline visit. And it was a higher risk for the long-term users, the ones that had been using it already at the baseline visit. So it seems to be a higher risk for long-term usage. So some conclusions. the body composition analysis of the antidepressant users shows that there are some changes that are hidden from simple body weight measures. There's a good reason to look closer than just looking at the weight gain, since tissue can the weight can be distributed in different ways, basically. So the female SSRI users were the ones who tended to increase in weight, but the male SSRI users really had a worse body composition profile. Overall, there was a tendency towards worse muscle composition with smaller muscles of less good quality when compared to the controls matched on sex, BMI, and age. CVD risk seemed to be increased for male SSRI users, not the female. For TCA users, there was a higher risk for developing type 2 diabetes, both for male and female TCA users, and this risk seemed to be higher for the long-term users. And I believe that was my last slide.
Thank you very much, Patrick. So now we're going to hear from Jori Mason about his findings.
Right, so just triple checking, is this, you can see it?
Yep, that's good.
All right, great. So I'll be talking a bit about what you can do when you can work with all the complete medical records and genealogies of two Scandinavian countries to look at the relationship between cardio and mental traits. So as everybody probably knows, and also Linn has talked about, is that there is a relationship between mental disorders and subsequent diagnosis of other disorders. So people with mental disorders are more likely to later be diagnosed with quite a lot of other disorders. For instance, you can see that here, this was done by our colleagues in Aarhus University, and they used the Danish registers and they looked at people with schizophrenia and without schizophrenia, and they say, are these people more at risk to be diagnosed with any of these disorders? And they found that the majority of these individuals of the disorder, people with schizophrenia were more likely to be diagnosed with a whole set of disorders. So basically, you should interpret this plot as on the x-axis is risk. So the further these dots are to the right, the more these people are at risk. And you can see this here, for instance, as an example. This is diabetes. So here you could interpret this as saying people with schizophrenia are 2 times more likely to subsequently be diagnosed with diabetes after their schizophrenia diagnosis compared to people that do not have schizophrenia. And the thing is that we know, and most of you probably will know as clinicians, is that this risk is in large part due to environmental contributions. Think about smoking or medication use given to treat schizophrenia, for instance, but also diet or alcohol use, or quite a few other things. But we also know that both schizophrenia and diabetes have a genetic underpinning. So there's genetics that contributes to these outcomes. And we also know that a little bit of this is shared between the two traits. So for instance, quite a few studies have already investigated this, and they found that there is a substantial genetic overlap between cardiovascular diseases and mental disorders. Big issue with these studies is that they often use clinical samples, so they're highly selected and they don't really represent the entire population. And also, none of these studies really look into what we call the relative importance of genetics and environmental contributions to this observation, to this comorbidity. And what do I mean by that is that if we look at this example of schizophrenia and type 2 diabetes, people with schizophrenia are 2 times more likely to develop diabetes, is how big of the pie, of this pie, is basically due to genetics and what comes from the environment in this case. So this is just an example. Let's say that 3/4 of this extra risk, this risk comes from the environment, and maybe a quarter of that is due to genetics. And we're trying to estimate the size of the piece of the pie, basically. So for that, we're quite blessed in Denmark that we can use with medical records. medical records of basically hospital visits. We can use that for research here, but also we have access to what we call the civil register, which contains information about when you're born, who your parents are, and how old you are. And we can link all this information to a family relationship database that we created, which is effectively a genealogy of the entire country of Denmark. And this allows us to compare family members, which gives us an idea about genetics and how much genes and genetics contribute to disorders. So from that, we can compare family members, but we have to take into account that if you just compare them as a binary outcome, it doesn't really help. Like, for instance, your risk for Alzheimer's disease when you're 5 is completely different when your risk when you are, let's say, 70. So risk really depends on when you're born, how old you are, and if you have any family members that have this disorder. So on the left, you see what we call a cumulative incidence plot of ADHD. And when you pick a random person from the population, you can estimate what this person's probability is to be diagnosed with ADHD. And for instance, somebody's risk at age 36, born in 1981, which is the bottom line, is, for instance, to be diagnosed with ADHD is less than 1%. While somebody who's since born in 2005, their risk is at age 10 or a little bit over 10 is 2.5%. So we see that your risk for a disorder is not equally distributed. But also we can compare family members. So for instance, in this case, the scales are not the same between the two plots, is that let's say if you're born in 2005 and you have a full sibling that has been diagnosed with ADHD, then the probability that you will be diagnosed with ADHD as well is 15%. So that's substantially higher than when we just pick a random person, and that in large part is due to genetics. So we can compare these 2 points with each other, and we can estimate how much genes or genetics contributes to this. And we call that the heritability, which is a measure on how well difference in people's genes, they account for difference in a trait. So effectively, how much of the trait is due to genetic differences. And you can see here, this is 14 cardiovascular traits, so cardiometabolic traits, and 6 mental disorders. And the take-home message here from this bubble is that all these traits have a genetic underpinning. However, some disorders have this more than others. And in general, for the majority of the traits, you could say that mental disorders have a larger genetic contribution than the cardiometabolic disorders. And the cool thing is that we're able to compare Denmark and Sweden. So Sweden has a bit more individuals than Denmark, and we compare these, and these are remarkably similar, so very stable. And from these distributions that I showed before, we can also calculate what we call the genetic correlation. So are people more at risk because the traits share genes? So we compared this for ADHD, for the 6 mental disorders, and 14 cardiovascular traits, or cardiometabolic traits. And for instance, here for ADHD, what we can see is that around 25-ish% of basically the genetic contribution of ADHD and a vast majority of cardiometabolic traits seem to be shared because they seem to run into families. And of course, it's not always the same. So you can see the top one is stroke, but then the bottom was atrial fibrillation. That doesn't seem to have a genetic correlation. But for instance, if we look at traits for anorexia, we can see that it doesn't appear that there is a genetic overlap between anorexia and any cardiometabolic trait. For instance, if we compare autism in this case, it really depends on what you're looking into. So some traits might share some genetic underpinning with autism and a cardiovascular trait, but not all of them. And this signal will be lost if you would analyze all these disorders in one group. So if you would say all mental disorders or all cardiovascular traits, it's very specific to what trait you're researching. Then I will go back to where I start, is that what is the relative importance of genetics and the environmental contribution to this observed comorbidity. So remember this first plot that I showed about schizophrenia and type 2 diabetes. That is this value at the bottom. We call this the phenotypic correlation. So how more likely are you to be diagnosed with, let's say, type 2 diabetes if you have schizophrenia? So that's the gray bar here. And for instance, that's the risk, the comorbidity, and how much of that in percentages is due to genetics and due to the environment. And these are the estimates that we calculated and I showed you before. So in this case, I could show, for instance, traits like ADHD, affective disorder, and schizophrenia, is that both genetics and the environment, they play a substantial role in this comorbidity. For instance, for traits like affective disorder, 50% of the risk and 50% of the genetic risk is coming from genetics, of course, and our part from the environment. So it's an equal distribution roughly. But for ADHD, the environment plays a little bit more of a role, but still genetics plays quite a substantial role, to around 40%. And the same goes for schizophrenia. But for instance, for a trait like anorexia, we only find evidence that the environment plays a role to this comorbidity. So let's use the example of type 2 diabetes. So people with anorexia are more likely to subsequently be diagnosed with type 2 diabetes. Yet this risk seems to be only explained by environmental factors and not by genetics. So finally, I would like to wrap this up by saying we find that there's clearly a shared genetic contribution to many cardiovascular and psychiatric disorders. And we can replicate this in Sweden, and it seems to work remarkably well, which is great. Also, the good thing is that we work with 2 complete populations. And so we don't have this issue where we work with ascertained studies, so people that are sampled from the clinic or people that volunteer for a study that tend to be more healthy than the general population. But also we can see that, for instance, traits like ADHD and cardiovascular diseases have a large genetic contribution, whereas the risk for cardiovascular diseases in people with anorexia seems to be fully explained by environmental factors. And I would wrap this up with my final slide, is how useful would this be for clinicians? And this is, I'm not a clinician, this is according to me, and hopefully some clinicians here will be the judge of that. But the difference in the underlying fact is that is affecting comorbidities have clinical implementations, I would say. I mean, we are getting there with CRISPR, but it's very difficult to intervene on the genetic determinants that affect the disease. But I would say it's more easy, quote unquote easy, straightforward to design interventions that modify environmental factors. So in this case, in our research has shown that it should be more easy slash straightforward to design clinical interventions to prevent or reduce cardiovascular risk in individuals with anorexia compared to individuals with ADHD. And therefore, I think these results could potentially end up useful in the clinic. And these are all the people that helped me out on this work. And it wouldn't be possible without them. Thank you.
Thank you, Jori. So we've had 3 great talks so far. I'm now going to give a talk that is a slightly different slant, and this is more directed at what you as clinicians or you as a patient can do about this research. So just going to share my screen. Okay, so this is a sneak preview of what I'm talking about when I say guidance. It's not quite the final version because that needs to be signed off with the graphic designer. But when I keep saying guidance, this is the sort of thing you have in mind. Basically a 3-page document that gives tips and advice on how to communicate these sorts of findings with patients. So that's the end product. And how did we create it? Well, we started off with a focus group with 6 people who had experience of mental illness, and we asked them to I showed them some slides demonstrating CoMorMent findings, sort of a summary of the sorts of things we've seen today. And then I asked them to think about how could this information be communicated by a health professional in a way that actually helps and supports the patient. After the focus group, we then went and I wrote up the draft guidance, and then I sent it back to the focus group participants to ask them to check and make any edits that needed to be made. So having introduced you to the guidance itself and how it was made, I now want to take you through a few of its key themes. So the first thing is that it's important to understand not just the findings, but how they fit into the patient's life. So as we've learned from these talks, it's certainly not the case that an individual is able to completely manage their risk on their own. There's a lot of elements that go into managing cardiovascular risk, and some things are simply not modifiable by the patient. And as Linn mentioned, this can actually sometimes help patients reduce their sense of self-blame, because I think certainly in the UK, a lot of our society is focused on people taking responsibility for their own health, but actually often the portion of health that they can change on their own is actually quite small, and even the portion they can change with the support of the health services may not be especially large. It's also important to remember, like we learned from Patrick, that one size doesn't fit all when it comes to health information. So what might be relevant for a woman taking antidepressants might not be relevant for a man who's not taking antidepressants, for example. So this is a pretend CoMorMent conference, and the person at the front is talking about their findings. And this man here is thinking, this is really interesting. How should I use this in my practice? Should I just tell my patient about it? Well, there's a few things to consider in that sense. So just to clarify, I'm not talking about specific patient level data like a blood test. I'm talking about the general findings that we know from these huge data sets that give us a sense of what might happen for people with specific conditions. So it's worth bearing in mind, would it benefit the patient to hear about this? Would it perhaps just make them feel more worried without a solution? And something that I want to get across is that if you're going to tell patients about a risk, you also need to tell them about how you will help them manage it, or how the wider health service will help them manage it. So if the patient's not going to benefit, remember, this is not specific information about the patient as an individual. It is general information which may or may not help the patient. You could just bear this in mind when you're providing care and keep up to date with the latest research when you are making clinical decisions. On the other hand, if the patient would find it useful to know, it's important that the information is then presented in a way that is helpful and positive for the patient. So we came up with some advice on how to do this. So as I keep saying, there are many factors involved in health, and not all of them are going to be under the patient's control, and a lot of them are not going to be under the patient's control as an individual. So my background is in psychology, and it is notoriously difficult to get people to change their behavior without quite extensive intervention, and that is just the way that humans work. So we can't say you're at greater risk of cardiovascular disease, you need to do something about it. We need to say, this is how the health service will monitor and support you in managing that risk. Another thing that came up in the focus group was that some people had experienced that health professionals made assumptions about their competency based on factors like their mental health. So it was important that each patient is treated as an individual. As a rule of thumb, it's probably a good idea to present the key information and then give them some way they can read up more later on. I'm aware that some of this will already be second nature to many of you, but it's useful to have just to make that concrete and as a reminder. It's also important to remember that everyone with mental illness deals with stigma in one way or another, and changing physical health behavior is inherently more difficult if you have a mental illness. So it's important that this is borne in mind when speaking to patients. It's also important to think about how their community background might view mental illness and interventions when you're making recommendations for how they can support their health. So a few concrete examples. As we all know, exercise is generally good, and we are often advised that we should move more and move as much as possible. But some people with depression have a lot of difficulty even getting out of bed, and telling them to go for a run is just going to make them feel demotivated. So something that you might want to do instead is to focus on treating the mental health condition, which will then make it easier for them to engage with the general advice, and also recognize that even just getting out of bed 2 days a week instead of 1 is a positive step. In the same way as Linn was talking about, loneliness can be harmful to physical health, and therefore the generic advice is you should spend more time with your friends. But in some cases, people with mental illness, especially conditions like psychosis, experience a lot of stigma, and this can make it harder for them to make friends because of the way that they are perceived. So in this case, a possible solution is to refer the patient to a scheme that involves more social activities, such as gig buddies, which is where volunteers agree to go along to gigs with someone who otherwise wouldn't be able to attend them. So thank you very much for listening.